Okay, good morning. So the first case is a 53-year-old male, and in the requisition sheet, the clinician wrote it that the patient had the bladder stone, was detected by sonography, and this is his voided urine specimen. So for the current perisystence, the the main purpose for the perisystence is to reduce the rate of typical cases and to increase the diagnostic rate for the high-grade urothelial carcinoma. So for this case, in the clinical history, we already know that the patient do have the history of urinary bladder stone. So when we screen the case, we do identify a few cells with increased NC ratio and hyperchromasia with a more spindle or squamoid shape. However, the NC ratio is not exceeding 0.5. So in the perisystem, in their atypical chapter, if the cellular atypia can be attributed to any particular reason, such as renal stone. For this degree of atypia, we will just call this negative. So this is stone atypia. So for the stone atypia, it can cause hyperchromasia, increase NC ratio, as well as some squamous metaplasia. However, if the chromatin pattern, you didn't see a coarse chromatin, so here it's more like a smash chromatin, and the NC ratio is not exceeding 0.5, and you have a very like a definite clinical history that the patient do have a stone. You don't need to call this atypical. So here again, we do see a few clusters of cells with increased chromatia and the increased size of the nucleus. However, the NC ratio is actually not exceeding 0.5, and the chromatin pattern is not like a coarsely and irregularly granular. So for this case, we would call these negative. So in the perisystem, the terminology is negative for high-grade urothelial carcinoma. So the next case is coming from a 69-year-old male. So this is his voided urine specimen that we received about a few weeks ago. So on low power, we do not see like a nicely preserved intermediate. So here we have some intermediate cells. And then we have some superficial cells, but this is a male, so this is likely coming from the urethra or like an external meatus. And here we start to see some highly degenerated but atypical cell. So in the background, there are a few like a necrotic type of cell. So these can be due to degeneration. However, we can still see a few relatively well-preserved cells with increased NC ratio, coarse chromatin, and hyperchromasia. So in this type of specimen, it is a little bit difficult to determine whether this is true neoplastic or this is just because of the degeneration. However, because we don't see in the clinical note there is any history can be attributed to this type of tibia, and indeed it show hyperchromasia and high NC ratio like about 0.5. So we call these atypical urothelial cells. So this is our atypical urothelial cells. So the patient, the clinician go ahead to do the ureter scope. So in the bladder, they do not see the lesion, but in the ureter, they do see some papillary lesion. So this is the washing cytology from the patient's left ureter just last week. So we received the second specimen from this patient. So in this washing cytology specimen, we start to see more like a fragments of cells, and we do not see benign intermediate cells, because usually for the washing cytology, the washing is targeted at the lesion that they identify by the scope. So here we see well-preserved cluster of cells with prominent hyperchromasia, polymorphism, increased NC ratio. It's almost like above 0.7. Some atypical cells, although these looks like umbrella cell, but these still show high NC ratio and a little bit of hyperchromasia. So this is diagnostic for high-grade urothelial carcinoma. So again, we have this class of the cluster of cell, really high NC ratio, already above 0.7. And for the ureter washing cytology, usually the cellularity is not as much as the pelvis, renal pelvis, because ureter is a very tiny space. But we see almost all the cells have these high-grade atypical feature. So this is diagnostic for high-grade urothelial carcinoma. So like what we discussed the other day, that for the upper tract high-grade urothelial carcinoma or carcinoma in situ, in the void urine specimen, sometimes the cellularity of these atypical cells are very scant, and it can mix with the normal population. So for the void urine specimen, it is important for us to identify like these sort of like degenerated but still with hyperchromasia type of cells, and we call these atypical. For the prior case that is caused by the stone atypia, we call it negative. So the next specimen is coming from a 64-year-old male, and this is his pleura effusion specimen. So we discussed about the diagnostic threshold for body fluid specimen. So for this pleura effusion specimen on low power, you already see that there are some cluster of cells throughout the entire specimen. So this looks like there might be some issue, because it seems to be there are second population. So it's likely a metastatic carcinoma. But when we go to high power, so we really need to pay attention to the cytologic feature of these atypical cells and the adjacent, like a normal population, that we can be confident that these are mesothelial cells. So when we go to higher power, for this cluster of cells, the three-dimensional architecture is not as prominent as what we used to see in the metastatic adenocarcinoma. Additionally, when we are able to see these individual cells and we go to adjacent, like a normal individual cells that looks like mesothelial cells, they doesn't seems to have a very big differences just based on the cytomorphology. So this looks a little bit strange. Just on low power, it seems to be a lot of aggregates, tight cluster. It looks like metastatic adenocarcinoma. But when we get to high power, these cluster of cells do not show typical morphological feature of an adenocarcinoma, which is enlarged nucleus, vesicular chromatin, prominent nucleoli, and bubbly cytoplasm and three-dimensional architecture. It really doesn't show those features at all. So when you go to the clinical note on the requisition sheets, so the patient came to our ER department because he was an OCA. So his heart didn't beat, and he came to our hospital. So we do the CPR and everything, and his heart start to beat again. And then he had some effusion. So this is basically the effusion caused by the CPR. And when you do the CPR, I think everybody know how to do the CPR. That you just press very hard on your heart, and so it will actually cause some shading of the mesothelial cell to your pleura effusion. So this is actually caused by the treatment. This is iatrogenic. So these are not metastatic adenocarcinoma. These are all reactive. So there were a few scenarios that you will see some of these effusion may be not caused by the metastasis. And in very few conditions you will see aggregates of mesothelial cell. So this is a good case because Cytotech called it atypical. The doctor think it is a typical metastatic adenocarcinoma, but this is actually caused by CPR. This is a patient of OCA. So what is the true metastatic adenocarcinoma looks like in the pleura effusion specimen? This is a 69-year-old female with history of lung adenocarcinoma. On low power, the background seems to be very, very clean, and we have these big cells, some in loosely cohesive clusters, some as individual cells, but these cells are very big. On 4X, you already see it's much bigger than the usual mesothelial cells. And so we go to high power, so this is the classic morphology of a metastatic adenocarcinoma, that you will have vesicular chromatin, prominent nucleoli, abundant cytoplasm, sometimes with eccentric arrangement. Because this is already be treated, so for this case, it doesn't form very well organized aggregate glandular structure, but it shows prominent individual cell, suggests that this is poorly differentiation. But when you take a look of the cell, you can still see that the vacuolation in the cytoplasm pushing the nucleus to one side of the cells. So this is classic for metastatic adenocarcinoma. And there is almost no benign mesothelial cell in the background. Everything looks like a cancer cell. So this is in the scenario of recurrence like advanced stage disease. Another similar case, again, middle-aged female. And in this specimen, the background shows more inflammation. But these bigger cells still, it is very abnormal. So just based on the architecture pattern, it seems to be looks a little bit like mesothelial cells because there seems to be intracellular window, intercellular window. However, if you check the nucleus, the size of the nucleus is gigantic, and the size of nucleoli is almost as big as the adjacent lymphocyte. So this is definitely not normal. So these are cancer cells. So sometimes the poorly differentiated adenocarcinoma can look like reactive mesothelial cells, but the size of the nucleus and the prominent nucleoli, this is a feature that you won't see in the reactive mesothelial cells. So again, these are consistent with the recurrence, the patient's non-history of primary lung adenocarcinoma. So these specimens are positive for metastatic adenocarcinoma. So the next specimen, elder female, 84-year-old. This is a pleural effusion specimen. But she has a relatively different history. On low power, we see tons of cells and looks very big. And most of them were individual cells. So the patient had a history of gastric cancer. So for the gastric signaling cell carcinoma, usually it would present as individual single cells, and in the cytoplasm you can see mucin. So it is very rare that you can see cytoplasmic mucin in the lung cancer, but it is more common that you can see in the metastatic gastric cancer. So for this case, we have tons of single cells, mostly showing these individual cells, some with a signaling cell arrangement, and we do see some cells do contain intracytoplasmic mucin material. So the cytomorphology is consistent with metastatic gastric adenocarcinoma. So let's move to some of the findings of aspiration. So this is a case that we discussed on last Friday from the thyroid. So we discussed the differential diagnosis with this particular morphology, like loosely cohesive single cells, a lot of them showing eccentric plasmacytoid feature, and we need to think about the possibility of medullary thyroid carcinoma. But because of this very dense cytoplasm, as well as prominent nucleoli and lack of neuroendocrine chromatin pattern, we also need to think about an oncocytic follicular tumor. So based on the cytomorphology, although it looks very much like a medullary thyroid carcinoma, but because of the nuclear pattern, no endocrine type of chromatin pattern, and we see distinct nucleoli, we still favor this is oncocytic tumor just based on the morphology alone. So we perform two immunocytochemistry. The first one is calcitonin. So if it is a medullary thyroid carcinoma, you will see cytoplasmic expression of calcitonin, which is negative. Additionally, we also do a TG thyroglobulin. So you can see most of the cells showing cytoplasmic expression of thyroglobulin, which suggests that the origin of these cells are follicular cell instead of C cell. So this is a follicular cell derived neoplasm. So based on the cytomorphology, this is an oncocytic tumor. So we will sign out the case as TBS category 4, suspicious for a follicular neoplasm oncocytic type. So So the next specimen is also a thyroid aspiration specimen. So we've already been quite experienced with this type of specimen, low power, hypercellularity, but no colloid. And then we start to see some architectural pattern, some complex papillary structure, as well as monolayer sheets of flattened cells. And then when we go to high power, we just need to confirm the nuclear features of papillary thyroid carcinoma. So these cells all show like an oval shape with a little bit like a disorganization, like the long axial crossing with each other. And then we just need to check if we can find pseudo inclusion somewhere. Yeah, sometimes it's not easy, but almost every cells in these specimen and looks have a nuclear feature of PTC. Additionally, this is what we call the aborted like a papilla. So you see like a three side of the cluster showing luminal border and one side is blunted. So this is a detached decapitated papilla, also very typical for PTC. Here we start to see fibrovascular stroma. So this is a true papilla because they are capillary within these papilla, and there's like a luminal border around these fibrovascular core. So this is also a true papillary architecture. So this is positive for PTC. So we will sign this out as TBS category 6, positive for papillary thyroid carcinoma. So we also see yeah, multinucleated giant cells is also common in the PTC. So this is positive for papillary thyroid carcinoma. So the next specimen, 56-year-old female, coming to our hospital because she had pain in the hip. And then through the image study, they identify bone lesion and they suspect it is metastatic lesion. So they do the biopsy and aspiration of the bone. So there's an osteolytic lesion. So this is a bone aspiration cytology. So we have some blood and we also have some aggregates of atypical cells. So these atypical cells showing increased NC ratio, hyperchromasia, and the chromatin pattern is sort of like a coarsely granular. So in a 56-year-old female, so just based on the morphology, it is positive for carcinoma, but we see this hyperchromasia, coarse chromatin type of pattern. It looks a little bit squamoid just based on the Papa-Nicolau stain. So in the female, if you have these type of squamoid cancer cells, the first possibility that you need to think about is breast cancer. So most of the breast ductal adenocarcinoma will have these squamoid type of cytomorphologic feature. And the patient doesn't have any non-history. So we wait for the staining result coming from the concurrent biopsy. So the biopsy is GATA3 positive and P40 negative. So if it is urothelial carcinoma, it can also show a squamoid morphologic pattern, but usually the P40 will show co-expression along with the GATA3. But in this case, we see GATA3 positive, P40 negative, so it is most likely coming from the breast, and the patient doesn't have any history. So this is her very first specimen, diagnostic specimen in our hospital. So this is consistent with metastatic breast cancer, so the patient need to do additional stain to find the primary tumor. But just based on the morphology, our first guess is also coming from the breast. So the next specimen is coming from a 64-year-old female who presented with neck lymph node enlargement and who has been followed in our ENT department for almost half a year. So I think initially they used some antibiotic for the treatment, and the lymph node seems to be like a shrinkage in size a little bit, but still it was there. So it's go on and off, on and off. And finally, after 6 months, the clinician decided to do the aspiration. So this is her aspiration cytology. So sometimes, I mean, this type of specimen usually is a very big challenge. So we've often encountered patients who just go to the ENT department with enlarged lymph node, and sometimes we make diagnosis of metastatic colorectal cancer in the neck lymph node. The patient go to the ENT department, and in this situation, in this case, particular case, it looks like it is a lymphoma. And it is a high-grade lymphoma. So we see mostly individual cells. In the background, we can still appreciate some reactive, mature lymphocyte. But if you compare the size, the shape with these highly atypical enlarged cells with prominent centrally located nuclei, so these cells are definitely normal and it is big. And so it shows these high-grade morphological features. So the cytomorphology of these atypical cell, single prominent nucleoli in the center, this looks like immunoblast. So just based on the cytomorphology, the most likely diagnosis for the case is a diffuse large B-cell lymphoma, post-germinal type, because it shows this immunoblastic type of feature. So in our hospital, whenever we see a new patient with the feature of lymphoma, we would usually confirm with CD3 and CD20, so just for the confirmation. Based on the cytomorphology, it is diagnostic for the lymphoma, but occasionally we will see some like unusual situation, some other small round cell tumor will mimic the morphologic feature of a lymphoma. The most notorious one is a small cell carcinoma, but the other small round cell tumor, even sarcoma, can show like a similar morphologic pattern of lymphoma. So whenever we want to confirm if the cell origin is lymphocytic, like a lineage, we want to go to the Lu stain, the Giemsa stain, and we want to identify a basophilic granular ring around these atypical cells. So we call these basophilic rimming. So this is a pretty good sign, suggests that these are lymphocytic lineage. So sometimes the cytoplasm are very, very scant, but you can still see a very thin basophilic rimming around these atypical cells. So these are most likely to be lymphoma. So we will wait for the staining result. So the next specimen is coming from a parotid aspiration cytology. So on low power, we see hypercellularity and a lot of cell in very tight aggregates, and it looks very dark. So on low power, it looks like a positive for malignant cells, positive for carcinoma. So when we go to higher power, these cells do show hyperchromasia, coarse chromatin, increased NC ratio, and a lot of them do show a squamoid type of morphologic pattern. So this cell looks kind of squamoid in an elder female. the possibility, if it is a primary parotid gland tumor, the most likely diagnosis is a salivary duct carcinoma, which is basically a salivary gland analog of breast cancer. So it will show similar morphological feature of these like a squamoid type of feature. And it can be de novo or it can be arising from a pleomorphic adenoma. So it can be a carcinoma X pleomorphic adenoma. Additionally, it can also be metastasis. So salivary gland is also one of the location that will have metastasis. The most common metastasis is the head and neck squamous cell carcinoma from the skin. Yeah, so because this type of elder patient, it's not that common in Asia, but it is more common in Caucasian group. They will develop UV light associated skin squamous cell carcinoma because head and neck is the area with high exposure for the UV light, and it can also metastasize to the parotid gland. So the most common metastasis is head and neck skin squamous cell carcinoma or melanoma, which is also uncommon in Asian group, but it's more common in the Caucasian cohort. So we would do a cell block for this one. We sign out these as a high-grade carcinoma, so it can be either primary or metastasis. And we can do some stain if we have some material in the cell block preparation. So that's for all the case today.
Thank you, doctor.
Thank you.